Regulars can join as we get into this. So, welcome everyone. My name is Doug Maynard. I'm the Associate Director at CAPHC, and welcome to today's presentation, which is about the Pediatric Rehabilitation Reporting System, or PRRS, which many of you are familiar with under another name, the old name being the National Data Set. I think PRRS is a much nicer name, and we'll be able to talk to a lot about that in a few minutes. But I'm just going to give a bit of an introduction on how this process is going to work, as I'm sure many of you may have realized that you are muted already. The audience is muted and the panelists are not. You will be muted. There will be an opportunity to ask questions. So I'm going to give you a few instructions about how to ask questions. I can see most of you are logging in using the audio on your computer, the microphone and speakers on your computer. If you do want to ask a question, that may or may not be your best choice of technology to connect to the webinar. If you want to ask questions, there will be a raise your hand button on your control panel, and if you do have a question, you can click that raise your hand button. We will unmute you, and then you can speak. Now, many computers in hospitals and other organizations don't have microphones on them. They have speakers so you can hear me, but once we unmute you, you may or may not have a microphone that will allow us to hear you. So if you do want to ask a question, you may want to switch over to the telephone. There is an audio section on your control panel. I think it's right at the very top of the little GoToWebinar control panel. If you do switch to the telephone, make sure you switch that audio setting over to telephone as well. So there's two choices, microphone and speakers or telephone. If you do switch it over, if you do dial into the telephone but do not switch it over, there will be all sorts of echo and all sorts of horrible stuff will happen, and I'll just unfortunately be forced to mute you again and we won't have a chance to hear your question. So it's in your best interest, if you do want to really participate in the question and answer period, to either dial in by the phone or be sure that you know how to work your microphones, or be sure you have a microphone and know how to work it. The other opportunity to ask questions, if you do have some sort of technical difficulty, is you can type your questions in. I'll be paying attention to the question box, which is at the bottom of your control panel. If you do want to type your question in, please feel free to do that as well, and I'll just introduce that to the audience. So before I hand it off to our panelists, I just want to give a sense of who's out there in the audience. I mean, this is a topic that has been of great interest to the CAPHC community and to the rehabilitation community across the country for many years, since we started this work with CNCYR many years ago. And if anyone who's been at the CAPHC conference, at the CNCYR symposium, and heard the presentations about that, or any of our webinar-based presentations and updates over the last few years, you are certainly well aware of the interest from coast to coast. So I'm just going to go through the organizations that are connected, just to give everyone a sense of the breadth of this. And it really is coast to coast, large to small organizations. So I think we'll really have an interesting discussion at the end of this presentation. So we've got the Children's Treatment Center of Kingston in Kingston, Ontario. We've got a number of individuals from a number of organizations in Alberta Health Services, including the Glenrose Rehab Hospital and Alberta Children's Hospital. We've got a couple of network members that have joined us today. We've got the BC Association for Child Development and Intervention, BCA-CDI, and we also have OCRS from Ontario, the Ontario Association of Children's Rehab Services, and many members from within each of those. We have many individual members from within each of those networks. We have the BC Centre for Ability in BC, and in Ontario we have the Children's Rehabilitation Centre in Algoma. We have the Children's Treatment Centre of Simcoe York, Grandview Children's Centre, Kids Ability in Kitchener, I believe they're in Kitchener, Lansdowne Children's Centre, and we also have McMaster Children's Hospital. Also from Ontario we have Holland Bloorview Kids Rehab Hospital. We have the IWK Health Centre in Halifax. We have a number of individuals from the PHSA in BC, which I believe is the Provincial Health Services Authority, I believe. Yeah. And we have one Kids Place CTC. And in, we can't forget Manitoba, we have a few folks from the Rehab Center for Children in Winnipeg. And we also have a couple of colleagues from the Rehabilitative Care Alliance, which is based out of Toronto. So as you can see, it really is coast to coast. Oh, and we also have the folks from the Janeway Health Center in Newfoundland. So as you can see, it really is coast to coast, large to small. So just demonstrating the interest in this topic that has been, throughout the last few years of this work. I think without any further ado, I'm going to hand it over to Shauna Wade, who joins us, who's a Senior VP at, Senior VP? Shauna, you have to correct me on your exact title, Shauna, VP or Senior VP at, or Director actually, sorry, Director at Holland Bloorview Children's Rehabilitation Hospital, and also co-chair of the CNCYR Operations Committee. And I'm just going to hand it, and part of this work for many, many years. So I'm just going to hand the presentation over to Shauna Wade.
Thanks, Doug, and thanks for the elevation in my status. I hope a raise comes with that too. So maybe you can move to the next slide, because it shows the agenda that we hope to cover, and we will cover throughout this webinar. I'll tell you a little bit about our objectives and the move from the national data set to a national pediatric reporting system. Have you moved the slides forward, Doug?
Yeah, just it was just.
There you go.
There we go.
Okay, so I hope everybody sees our agenda there. Then we're going to talk a little bit about what this will mean for you, which is an important discussion. Then we'll open it up to all of you to ask questions, and we can have some discussion around PRRS, and then wrap up with some of our next steps. So do you want to give me the next slide, Doug? So we've heard about who you are, and I want to refresh for you as to who we are and who is speaking today. So today we, CNCYR, the Canadian Network of Child and Youth Rehabilitation, and CPDSN, you're going to love all these acronyms, but CPDSN stands for the Canadian Pediatric Decision Support Network. Our two groups have come together to discuss the implementation of a national pediatric reporting system. The origins of this national pediatric reporting system has been a strategic goal of CNCYR for several years. This year is a watershed year for our group in that PRRS will transition to CPDSN, the Canadian Pediatric Decision Support Network. The speakers today represent leadership from both CNCYR and CPDSN. Myself, as Doug said, I am the co-chair of the CNCYR Operations Committee, and my day job is at Holland Bloorview in Toronto. Heather Osborne-Vincent is also on the call, and she is my co-chair for the Operations Committee, and she is at IWK in Halifax. Sonia Peguera is the co-chair of the CNCYR Outcomes and Benchmarking Committee, and she too is from Holland Bloorview in Toronto. And her partner is Sandy Lippman, who is representing the Glen Rose Hospital in Edmonton. Both Sandy and Sonia, their positions will transition their leadership to CPDSN. We also have on the call Leah Boone, who is the National Coordinator of CAPHC-CPDSN, Siam Javid, who is the Health Information Analyst and Project Manager, again for CPDSN. You heard that Doug Maynard, who is the Associate Director of the Canadian Association of Pediatric Health Science Centers, is on the call as well. And then our foundational leader for all of this work is Elaine Orbine, who has joined us today and will be leading some of the discussion, who is the President and CEO of the Canadian Association of Pediatric Health Centers. So that's who we are. We know who you are. So why are we all here? So as key stakeholders in this work, we are keen to share with you our findings from the 2013 consultation that we had in Toronto last year. And we also want to give you some rationale and reasons as to why we are shifting this work to become under the umbrella of CPDSN. This is truly a call for action. PRRS is at a point in its development where it has become a reality. And it is important for you to know what the near future holds and to stay and or become involved in this exceptional, groundbreaking work. Next slide, please. So this little guy is my favorite little guy, the Lorax. And this is how we felt when we started 8 years ago on this national data set. Unless someone like you cares a whole awful lot, nothing's going to get better. It's not. So this is the beginning of our story. Our small but mighty pan-national group had a dream. We had a dream of a pediatric reporting system specifically related to rehabilitation. And for the past 8 years, we have been working towards this goal. We are now at a point to truly move this project into a national pediatric reporting system. So for us to move ahead with the same spirit of inquiry that we had when we started this initiative, we briefly want you to tell our story, which is really your story, in order to lay the foundation for our future growth and development. So at this point, I'm going to turn it over to Sandy Littman, who is going to walk you through some of those foundational moments.
Now, next slide, Doug. Hi. So glad you're all here, and I'm happy to be here too. CNCYR developed back in 2004 really as a group of people from rehabilitation facilities across the country to get together as a network to look at some work that we had in common, some interests that we had in common, and just develop a structure that would enable us to be able to act on some of those ideas and concepts that we had. Our first bit of our work was really to define who we were and to establish what we were trying to achieve. And one of the first ideas out of the gate, and the one that's really been driving us and really initiating a lot of this work, has been the desire to have a report card, a national report card for pediatric rehab. There wasn't a lot of information in the literature about pediatric rehab services. There wasn't much consensus about what those services should look like, and there wasn't another venue where we could all get together and talk about these issues, develop priorities, and work together. So that first, we had actually 4 objectives in those early years, and that, starting off with developing a network, etc. But the objective of developing a national report card was the one that has really led to this work. So we agreed that this was something that was a high priority for all of us, and we established an outcomes and benchmarking committee from out of CNCYR to look at how we would go about doing this work. So next slide. So the first order of business was to develop a conceptual framework. We wanted to know what people wanted to know. What should this report card consist of? Why do we want to know this? Answering that question would help inform what the data set would look like. And we wanted to know if there were certain imperatives that were driving this. So why was everyone so interested in this? Were there philosophical reasons, ethical reasons, fiscal reasons? And we had over 4 years, I think it was 2006 to 2010, we had a series of surveys that we sent out to our national stakeholders. We had a National Advisory Council that we brought together annually to discuss and to try to develop the framework for a national data set. We had expert panels, lit reviews. We did a lot of work, and we did develop a consensus on what the conceptual framework would look like. So next slide. So because there were a number of drivers to this, so there were fiscal drivers we wanted to know, and our who we reported to wanted to know what how effective were our services and how efficient were our services. So what was our resource utilization, and how was that resource utilization, what kind of results were we getting for the resources we were using? There were political considerations. Accessibility was a big one. It was in the newspapers, it was at our boardroom tables, at our managerial tables. We knew there were long waits for many services, and there were strong imperatives to address those. So when we looked at all of the drivers, we decided that there was one key lens that we needed to look at our report card through, and that was the Canadian Accreditation quality dimensions. So that covers the accessibility, effectiveness, efficiency, and patient-centered care. In our case, we're looking at client and family-centered care. So that was one of the lenses that we needed to apply when we were developing the data set. The second lens was really centered on the effectiveness dimension, but it was coming from a philosophical perspective. So as we were moving in the children's rehab field to look at children's rehab from a World Health Organization International Classification of Function, child and youth perspective, so moving from focusing on impairment, body structure and function, and having a broader lens on how to look at rehab, how to look at rehab goals, how to measure effectiveness. It includes activity, participation, environment, and personal factors. So through all of our consultations, we chose those two lenses to use when we were developing the data elements for our national data set. So that's the structure, the framework. Our data elements follow that framework. So what data elements do we have to focus on to be able to answer the questions from that framework? So we now know the kind of the why and the what this would look like. We wanted to, in 2012, confirm that we were on the right track. So next slide. So we had another consultation in 2012 and brought together stakeholders again from across the country and asked them, what are your hopes and dreams for this national data set? Why are we still committed to doing this, and what do you want to get out of it? So it was really very interesting and very reaffirming that people were still very interested in this, and they were pretty consistent in what they were hoping to get out of this. Now, we had just been coming out of our first pilot, and we'll talk to you a little bit more about that in a bit. But one of the most important things that came out of, one of the most consistent responses was that they wanted a consistent reporting of outcomes. They wanted a consistent indicator definitions. So this whole concept of having a common language that they could talk to each other in, that common language that we could use to look at outcomes was very, very strong. And they wanted that common language to include the number of the data elements that we had been looking at. So wait times, that addresses the access issue in the quality dimensions. Services, what types of services are children getting, what intensity of services, and then outcomes, what is the impact of the services. I think one of the most important things that came out of this is that there was still a commitment to have this national data set for the purposes of improving services, improving quality and safety. They wanted to have this common data to be able to inform their quality improvement initiatives, and ultimately, and probably most importantly, to use that data to be able to improve outcomes. So next slide. So consistent with the drive from the beginning to have a national report card, they wanted to be able to use that national report card to better understand models of service delivery, to be able to do benchmarking, to be able to look at promising practices across the country, to learn from those, and to be able to improve services through that examination. They wanted to better understand the population. So, you know, that the point was made and has been made from the beginning is that if we don't have data to tell us how our children are doing, how do we know how we are doing as service providers? How do we know if our service changes are resulting in outcome improvement? They also wanted the data set to support equity across the country and across populations. So another important lens to look at this through was our children being able to access similar types of services for similar types of benefits. They also wanted it to be useful for research purposes. So not that the data set would be developed for research purposes, but they wanted the data to be reliable and valid enough that it could be mined to answer important research questions. Next slide. So we now have a consensus of what types of things we're going to measure, why we're measuring it. We definitely want to go forward, and we then needed to go through the process of looking at what methodology we would use and how feasible is this really to do. We started off with two initiatives. On the slide you'll see we started with wait times. We actually started with two dimensions. One was the wait time data element. The other one was, the other one was measures of processes of care, so family-centered care, child and family-centered care. So these kind of happened in parallel, but we learned a lot from those two little tests of concept and tests of feasibility. The wait time one, it took us a long time to establish a consensus on definition. Everyone was defining wait times differently, measuring it differently. After considerable work and consensus building, we decided on 3 data elements to be a proxy for a measure of wait times. And using those 3 data elements, we did pilot wait time data collection, but we saw some of the issues that we were going to be faced with in the bigger data set. Same thing with the family-centered care. There were issues with privacy, issues with data sharing, data collection, data storage. So we knew we had a lot of work to do. We knew that we were in both of those initiatives. We were able to gather data and had some very interesting preliminary findings, but we could also see that there was a lot of work to do. At that point, we established the data elements working group, and that working group was pulled together to look again at that effectiveness dimension. and decide on which tools were best to measure that. One of the challenges we met there is that this was really an emerging area. There were a lot of assessment tools that were in development that were not quite there yet, promising but not ready to be used. But we did the Data Elements Working Group, which consisted of a group of researchers, administrators, clinicians, did come to a conclusion about 3 tools that we could use to start out with. And then while we kind of kept our eye on the emerging area to see if something else was coming up. So in the summer of 2012, we embarked on our first pilot. We had at that point the front end of the data set pretty well established and agreed on. So it was mostly the administrative data and the descriptive data about the child, about the children. And so we had that first pilot looking at is it feasible to collect this administrative data. We had, I believe it was 5 sites in that first pilot. And we learned a lot. It was definitely worth doing. We learned a lot about some of the issues with collecting consistent and reliable data. Everyone had a different systems for registering their children, and a lot of the data collection had to be hand done. Can you move to the next slide? So because we had a very short window for data collection, we had spent a lot of time that year establishing our definitions for the data elements that we were going to include, developing a manual for data collection, developing establishing which kind of methodology we were going to use. It was decided that we would collect the data retroactively. So, next slide. So that was, I think, one of our biggest challenges and one of our biggest learnings from that first pilot. The conclusion from that pilot was that retrospective data collection seriously compromises data quality. Most people were collecting their data from chart reviews, and I think there were a lot of learnings at sites about some of the issues with their charts, so there was a little kind of side benefit to doing this. But we did learn that we needed to tighten up our data element definitions. But we also learned that it was feasible to collect data, to have it stored in one site, and to analyze it. And we were able to generate some very interesting, although very preliminary data. So we moved from there to our second pilot, and now I'm going to hand it over to Sonia Figura to tell us about our second pilot.
Great. Thank you so much, Sandy, and thanks everyone for being on the line. I know that we've been kind of going through this a bit quickly. It's just been a lot of work, but we wanted to give and touch upon the high points of all of this work, and it's just been amazing. So taking to pilot number 2, which really embarked on the summer of 2013, there were so many valuable lessons, and the key point that Sandy had mentioned was that while a retrospective data abstraction was wonderful just from a feasibility perspective, what was very clear to us is that not every organization had the same processes in terms of how they collected data, how it was stored, and then from an abstraction perspective, it would make it very, very difficult to ensure the quality of the data, the rigor in terms of how we collect it, and then the analysis. So the group, the actual steering committee and the group had said, well, we really now need to take this and scale it to a prospective study. And so looking at the pilot sites that had historically embarked upon the first pilot, and adding a few was really saying, okay, we now have these data elements. We're now going to add a few others, which were around function and activity, as well as participation and service intensity from a parent perspective, and really working with each of the sites to change the practice, because not everybody actually collected this information, and ensure that we were collecting it in a consistent fashion. What we found from this is that definitively it improved the data quality, without a doubt, because we were trying to align and standardize the processes. We also found that there were some variations from province to province, and that's where we were really looking at this and saying, oh, there is potential for this. This is the original purpose of why we embarked upon the national data set, which is now called PRRS, was really to fill the gap in pediatric rehabilitation and treatment centers. And now we were able to see in a very preliminary and descriptive way that there was potential use for this information, and our original assumptions were well-founded, and that we really needed to look at how we could make this in a more structured and standardized approach. But in this interesting findings that came, we also recognized that there were some issues with privacy and consistency of definitions, because not everything was fully aligned, and that some of the tools that we were using really needed a bit of refinement. Could you advance to the next slide, Doug, please? So, and the reason we're actually coming into the things for consideration, because this really sets the stage very nicely as to why this partnership with CPDSN and with CAIHI that Leah and CM and Elaine will be getting into over the next couple of slides, is that these elements that we actually struggled with a bit, or the challenges that came up, we could really see how this new structure would help remove those barriers and in fact facilitate the information flow so that it could be utilized at a broader perspective. So privacy definitely was one of the elements that we needed to consider, because we know that province to province there are subtle differences from privacy, and where some are regional privacy officers, others are more local, and how do you then align all of the privacy issues to ensure that the information can flow so that there is system comparison. Data collection and data quality. Again, this was in our prospective while we had worked with each of the sites and the facilities to try and align and standardize the way that we were collecting the information. There were still some subtleties. Some of them were around the data elements. Some of them were how they were collected and the interpretive piece from the sites. So looking at those practices and changes, we figured that as the next iteration came about, we really needed to consider how we would standardize this. Human resources. This was part of the feedback that many of our partners said that, yes, this is great, we're participating this in a pilot capacity, but as we start to think about normal day-to-day operations, there is a human resource cost to this, and what might that look like? And then thinking about how do you lever that within the organization to say it's worth either attaching resource or reconfiguring the way that operations are done to collect this information. And so these were some of the real-time realities that some of our pilot sites were feeding back to us. Next slide, please, Doug. The costs, there were, again, many of the sites saying, okay, well, not only are there the soft costs, which are the human resource elements, but what about the hard costs? So what might that look like from our information management system, from our decision support elements? How are we going to administer this? If some of the tools were computerized, would that be a hard cost for the organization? What if the costs weren't absorbable, and what might that be in terms of participation in a future perspective? So these were some of the elements as well. And the analysis piece was, as we were going through, we still found that there were inconsistencies and data elements in the way that we collected the information. So we had to ensure that there was further training, further standardization, so that the reliability and the rigor attached to that data would make it very meaningful information. And finally, the data piece, the technology piece, was ensuring that we recognized that there were variations across sites. Some sites, all of the information was abstracted from their electronic health records, whereas others, it would be a manual review, and what might that look like? So we really had to consider that there would be consistency in collection, and also recognizing that sites may have different mechanisms. Next slide, please. So from the moving forward piece of it, in 2013, we did have a broader stakeholder consultation at the CAPHC conference in October. And what was established was really some very key priorities to think about. We've done our feasibility study. We've now done the proactive or prospective pilot study, but we can't continuously keep calling this a pilot. We actually have to step off the cliff and say, yes, that we believe in this system, we know that we need the information, we know that there's great utility, and how are we going to move this forward? So part of this was to ensure that we looked at a broader engagement and communication. We really thought further about how we would collect the information that would be meaningful across sites so that it could have levers from a provincial perspective, from a local perspective, from a pan-national perspective, and thinking about how we would embed this from a clinical practice element, and then having the support of actual organizations. So there was a lot of conversation about we really need to consider these elements and perhaps a partnership that would allow us to move forward. Next slide. And at this point, I'm going to be turning this over to CM. But before we actually go to that next step, what I would like to do is to perhaps stop and ask if there are any questions. I believe that Doug will be actually doing this. To pause.
Yeah, so if anyone has any questions for related to the information that we just presented before we move on to the next component of the presentation, please either type your question into the question box or click the raise your hand button. I did want to add, I noticed I can see sort of how the connection status, the audio connection status for people, and I can see a few of you did not enter the 2-digit PIN number. If you didn't do that, then you won't be able to be unmuted. So there's just if you look under the audio section of your control panel, if you still see it displaying a 2-digit PIN number, you just have to enter it into your telephone now. It's usually pound, the 2 digits, and then pound. If you don't see the PIN number, then you've done it correctly. Most of you have. There's only 1 or 2 that have not done that. So, someone's asked a question. Are you able to give some examples of the data that was collected?
Sandy, do you want to speak to that, or would you like me to?
Go ahead, Sonia.
Okay, thank you. That's an excellent question. So when we were looking at this, we were looking at administrative data, descriptive data, as well as service alignment and outcomes data. So from our descriptive data, it truly was looking at the population type. We were very focused on CP and autism as the 2 populations that we were starting. We were looking at age, we were looking at gender, we were looking at where they were receiving their services. We looked at wait times in terms of access, so time of receipt of referral to time of first appointment to the time they first received treatment. From an outcomes perspective, we looked at the Pediatric and some organizations at the PEMCY, as well as looking at the resource intensity tool. And that was really trying to focus on some of the out-of-pocket expenses that families were basically incurring in order to receive treatment, as well as where they were receiving treatment. Was it more in a hospital? Was it more in a rehabilitation setting or community? Was there private or public pay? What types of services were they receiving? Where were they receiving those services? We really kept to a narrow data element structure because we didn't want to go to hundreds of data elements. We wanted to ensure that we could collect the information reliably and that the information we were collecting was typical as part of many of the processes that the organizations actually in their day-to-day activity collected. Sandy, did I miss anything from that?
Well, just as one specific example that might be helpful, when we looked at the wait times data, we saw tremendous variability across the country in terms of how long children were waiting to be seen after they were being referred. So, I mean, the range was mind-boggling. And even within organizations, for different populations, there was significant variability in wait times. And so that really led to some very interesting discussions. So you look at a facility that has a very short wait between when the child was referred and when they were seen, compared to one with a over a year wait, for example. Well, what are they doing differently? Are there some things, some initiatives that the facility that has a very short wait time has instituted, or some practices that they've instituted that have helped to shorten their wait times? So it just opens a discussion and allows us to look at where are there some promising practices and what can we learn from facility to facility.
The next question that came in was, what do you foresee in terms of the use of the PD?
Well, we have, I think we got some good information from it, and we used the PDCAT, the computer assisted data collection method, and some sites used iPads to do that, and they found it very good. So I think it's a very promising instrument to use and to continue to use, and gives some very good information. It's well-based, and very good reliability. We had, a group examining that pretty carefully. So I mean, I would see no reason why we wouldn't continue to use that.
All right, well, that's all we have for questions for right now, so let's move on to the next portion of the presentation. I guess we're handing it over to CNCYR.
Good afternoon, everyone. I'm just going to provide a brief transition from the National Data Set Initiative to the Pediatric Rehab Reporting System in collaboration with CPDSN and CAPHC. So why CPDSN, which stands for the Canadian Pediatric Decision Support Network? Now, I just wanted to highlight the utilization of CPDSN's collaborative and networking model to broaden the scope of understanding and analysis of pediatric health services. CPDSN provides insightful quantitative and comparability analysis, which allows and is demonstrated in the annual benchmarking report that is published each year. You will see that this annual report covers the pediatric surgical wait times, MIS, benchmarking, and clinical KPIs, just to name a few. The addition of CPDSN to the Pediatric Rehab Reporting System will provide data expertise and knowledge to support PRRS. Its mandate is to provide a national data sharing and benchmarking across the continuum of care. As Sandy mentioned earlier, just a few moments ago, that the PRRS pilot was able to provide variability and to demonstrate that variability from site to site. This benchmarking report is CPDSN's capabilities in terms of data analysis that, in collaboration with CAPHC, can just provide that data quality even further and enhance that. The guiding principles to CPDSN, again, I'd like to mention that it is guided by the collaborative model to support the work that it does and to develop capacity and stimulate new knowledge and practices. It is also guided by respect, transparency, establishing a national data standards, undertaking initiatives that will have national impact, such as the PRRS, and set benchmarks to promote best practice and enhance health outcomes. The Pediatric Rehab Reporting System plans to address, as it moves forward, people, process, tools. It is important to address these issues before we move before we move forward to the implementation phase. In order to do so, a comprehensive and communication and engagement plan must be in place. We are currently working on solidifying this communication plan with our CNCYR leadership. We're also validating requirements through stakeholder engagement and consulting on methodologies for data collection to ensure a streamlined process. To support this process, we plan to provide ongoing education and support, along with cost-effective, flexible, and scalable tools. I'll move forward and now provide you with a brief overview of the PRRS project map. I joined CAPHC in January during the transition phase of the PRRS from the national data set to the pediatric rehab reporting system. During these initial stages, we performed an environmental scan, which was conducted from January to March, where we consulted with the CNCYR leadership and the previous coordinator of the PRRS project. And we also met with CAPHC on February 18th and was able to confirm the cost of the data collection tools and platform requirements. A work plan was established in February along with a steering committee, which we will meet for the first time tomorrow. We have also confirmed the technical specifications with CAPHC and are working on confirming participation commitments, securing funding, and finalizing the plans to move forward. We're expecting to conduct a beta test. These dates are to be confirmed from October to December, and it is important to highlight here that CAPHC requirements due are on September 30th, 2014. I will now pass the presentation to Elaine to take over and complete.
Thanks, Yam, and I want to say good afternoon to everyone as well, and a great big thank you for joining us. This really is a national collaborative and a national opportunity to really move the pediatric rehab agenda forward in a very, very big way. Shauna, you mentioned our dream, and this really is a dream, and I think reaching the reality of that dream. And I'm also hoping that many of you that are participating on today's webinar who have been part of Pilot 1, Pilot 2, part of the dream from the beginning, are really sharing in what I'm going to refer to as a collective pride in our work together. So from a pilot to a pediatric rehab reporting system, what does that mean, or where have we landed at this point in time? So as Sam referred to in the previous slide on the sort of project map, February 18th of this year was a very important date and represents a very exciting milestone that we reached together as a result of our partnership and relationship for many years with CAPHC. And CAPHC has committed to the development of a pediatric rehab reporting system. And to reiterate, this is the first time ever. This is a first time ever. We also now, which is a very important practical piece here, we also have confirmation on the cost to develop that system. And we are looking at approximately $250,000, and that's to develop the tool, the reporting system itself. I'll provide a bit more information on that in the next slide. We are also, CAPHC has committed to a target go-live date of April 2015. And of course, the Pan-Canadian reporting opportunity comes as a commitment from CAPHC's Canadian Pediatric Decision Support Network. Building our collaboration, what will this mean? I want to share and on behalf of CAPHC describe our commitment, our ongoing commitment and specific commitments to this program going forward. So I mentioned the costs of developing our data repository or our pediatric rehab reporting system at approximately $250,000, and CAPHC is committed to fundraising those dollars to support that development piece. We're also very committed, and through this teleconference and webinar today, you've met Siam Javid, who is our project manager for our rehab program that joined us a few months ago, although Siam, it feels like many, many months ago now. We're also committing to continue to build and enhance a long-standing partnership with CAPHC and to continue to liaise with our colleagues on behalf of you, on behalf of our participating centers and member organizations around providing centralized assistance for questions, technical specifications, re-interfaces, which we recognize are going to be different from site to site, as well as the development of an RFP if required. And again, there's a few things that we need to know from our colleagues on the phone today, our participating sites, before we can move forward there. Education and moral support with a big happy face next to that. I think that's part of CAPHC's commitment to all of our programs and all of our partnerships, and that will be a strong commitment for our pediatric rehab reporting program as well. Increasing our knowledge translation activities. I know many of you participate regularly on CAPHC Presents and our different knowledge translation and mobilization work, and that will, of course, be a big part of this program and our commitment, as well as the inclusion, and this is one of the deliverables to our members, of course, and the benefits of participating, inclusion of our rehab data in pan-Canadian reporting through CPDSN's annual benchmarking report, and that's something that Siam also mentioned in her earlier slide. So the implications to our participating sites, or what will this mean from your perspectives? So as a participating organization, we really need your commitment to providing a lead resource or resources to represent you, to represent your organization on our project team or working groups. And there will be part of the CAPHC way, if you will, is always based on collaboration as a community of practice. Our work plans are developed by our participants, by our members. They're carried out by the members as well. So again, we do need that commitment of leadership from each of our member organizations. We also have to have your commitment that, first of all, you understand and are willing to expand your existing local EHR systems to enable the transfer of data, the transmission of data from your respective sites to CAPHC. And again, we put this in as an important point because we recognize and respect that the privacy policies across the country around data transfer, for example, differ tremendously, and one size is never going to fit all. So again, this has to become a responsibility of our individual participating sites. The third bullet, and that also includes resources as well as financial costs for that interface piece, not for the development of the reporting system, but in fact the mechanisms or interfaces that are required at your sites, your respective sites, to transfer the data. Participate in collaborative data collection, tool development via, again, an RFP for vendor selection if required. And again, we just have to see who's able to come and join us in the first part of the implementation phase, and then CAPHC is very committed, of course, to supporting the development of an RFP, if required, RFP for vendor support. And then lastly, commitment to an annual membership fee, not to support the development, but in fact the ongoing operational costs. That amount is approximately $60,000 annually, and if, just as an example, we have 10 participating sites who begin with us, and that could be a staggered beginning, if you will. If hypothetically there are 10 sites who join us, then that $60,000 will be divided by 10. And that's and there may be varying scales depending on the size of the organization, but again, it's going to be a shared cost by our participating members, and that is for the ongoing operational related costs. But we know that we're working with a total of approximately $60,000. Next slide. Better together, experienced, and new. So this is just a list. First of all, always an opportunity for us to say thank you and to recognize the participating centers who joined us in our second pilot, the pilot in 2013 that was described by Sonia just a few minutes ago. And also that last bullet on new sites. We really want to, again, communicate today that everyone is welcome, and our goal is to really engage as we go forward with Canada's child and youth rehab community from coast to coast. So there are lots of opportunities, and of course new sites are most welcome. Next slide. So what happens after today, and after this slide, we're going to open it up again to questions from everyone online today. So after today, we sort of looking to mid to late May. Everyone on the call today and others will receive a participation invitation package. As we put on this slide for our previous as well as newcomers. And through that, we will identify a work group in addition to the Pediatric Rehab Reporting Steering Committee. We will ask for a relatively short response, and we will give everyone approximately 1 month to the middle of June or so. And then, of course, we will follow up via many different ways of communication with our stakeholders to confirm your participation. And then, of course, work plan adjustment and implementation will follow. What I want to mention as well is that there isn't, we're not talking about April 15th, everybody has to be ready to go at that point. In fact, we are anticipating staggered starts, again, depending on systems in our participating member organizations and so forth. So there is flexibility there. The goal, of course, is to work together to build our community that will, in fact, be part of our pediatric rehab reporting system. And there will be a lot more information, of course, in the package of information that will come out to everyone in just a few weeks. So at this point, I want to, and I know I'm saying this on behalf of all of our colleagues who have shared in today's presentation and really sharing information, this rehab dream is coming true. It's coming true because of commitment and collaboration of many, 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 many people from across the country. We really believe we're going to achieve the goals that we've highlighted here for you, and really welcome your questions today. We welcome your participation. We need your continued leadership to really fulfill the dream. So I'm going to stop there and say thank you to everyone again for joining us. And Doug, open it for questions.
All right, so let's open it up for questions. If anyone does have a question, please either type it in as we had earlier or click the raise your hand button and we will unmute you and let you speak with our panelists. We don't have any questions right now, but we'll just give people a few seconds to formulate them or type them in or whichever route you're choosing.
Leah, I don't want to put you on the spot, but you're the only voice we haven't heard from today, and that's just not right. Any thoughts, comments, just sort of generally, of course?
Well, I have to say that I'm very excited about today in particular because it's been a long time coming. I know that many of you may not know, but CAPHC-CPDSN has worked sort of at arm's length with the censor group doing the first and second pilot, just sort of as an ad hoc consultant. We are very excited and we're very passionate about this mutual goal because as my colleague Siam pointed out earlier, CPDSN as the data sharing and benchmarking arm of CAPHC is all about really benchmarking across the continuum of care, getting all our children's population included in that work. We've done painstaking work across Canada in the past few years to make sure that we represent our Quebec colleagues as well. So we have some really good experience and lessons learned and really are very keen to work together under the same model. So I just encourage you to ask away. And we want to know what it is that you're thinking about. What is it that excites you? What is it that maybe gives you a niggle or you're not sure about? It's a great opportunity for just an open discussion.
Yeah, be sure the comments and concerns are welcome. We may not have answers at this point as we don't have all of the details of implementation worked out, and that's what conversations like this are about. So please, if you do have any concerns or anything, it may be something that's shared by others across the country, so please feel free to raise it.
Sandy, Sonia, Heather, or who did I forget? Shauna, how's it about?
It's Sandy. I just have one little comment. I wanted to just take this opportunity to thank Elaine for her the faith that she has shown in our group from the get-go, and without that kind of encouragement and support, we would never have gotten to where we are today. And with her continued support, and now bringing this under CPDSN, we really do see the near possibility, in the near future, the realization of our dream. So thank you very much, Elaine, and thanks to everybody for all of their hard work. This has been a lot of work, and I think the potential is there, and it's limitless. And we're all very excited to be able to get this going as a fully implemented pediatric rehab reporting system.
So we did get a question come in. The first one's from Cheryl, one of our close colleagues in Winnipeg, Cheryl Sosinski. She's asking if we could talk a bit about the data that will come back to us. Will we get our own site-specific data? What will be the frequency? Will there be comparator possibility, etc.?
I think Leah is probably the best one to take that one.
So Cheryl, that's an excellent question. So the quick answer is yes, you will get your own data back. But the big bonus is that in addition to your data, you'll be able to see data from all other participants. At CPDSN, when we collect data right now, which we do inpatient, ambulatory, ER, as well as some of the other examples that Siam referred to, we have a pretty rigorous process of pulling that data from CAPHC. Our members then work together with us on a validation process to make sure the data quality is there, and then we release the data through a report. In terms of frequency, Cheryl, I think that really is to be determined. I know, for example, in the last year, CPDSN, actually the last 2 years, CPDSN has worked to transition the Canadian Pediatric Surgical Wait Times data set to CPDSN. And last April was the first time that we went live with that and started actually having that data being sent to CAPHC. So at this juncture now, we have 3 quarters worth of data, and we are about to embark in validation. And from that, our members and in collaboration, we will establish a quarterly reporting cycle. So as Elaine mentioned earlier, we know one size doesn't fit all. We have various jurisdictions, and one of the biggest challenges in that is that not all jurisdictions provide their data to CAPHC at the same time, that ultimately it is our role at CPDSN to be able to parse that data and make some regular cycle of reporting. And so you can sort of expect that the first year, once the data is in there, will be a little unregimented as everybody sort of starts to come on board. But as you sort of get in the groove, as you do with any data collection process for any data set, you do find that groove of when data is available. And we've managed to do it, including Quebec, and I have no doubt that we can do it in this case. Does that really answer your question, Cheryl?
And Cheryl, yeah, she said yes.
Yes, okay, thank you.
If you want us to unmute you, just click that raise hand button, and we'll be happy to do that if you want to speak.
We'd love to hear your voice.
The next question that came in is from Dr. Failings at Holland Bloorview, and she's asking about who is on the steering committee. And I think, I don't know if we've got all that list confirmed yet. It is the people who have been invited to participate in the call, which is taking place tomorrow, all mostly come from the folks who have been part of the work to date, so the representatives from the various CNCYR committees that started this work, the Outcomes Benchmarking Committee, and a number of the national data set working groups that were developed over the last few years. So a number of them have been invited to come forward to the group, as well as a number of sort of the data experts that have been part of CPDSN's work. Most of them come from that CNCYR group and that rehab community, but we're adding a sort of a layering of those data and informatics experts that can help push the project along. So the folks who have been invited initially will be meeting tomorrow, and I think we'll still be continuing to populate some of the gaps. Once we see who's interested and willing to commit the time that's necessary, then we'll see where the gaps are and be continuing to add, I think, and populate. I think Leah has something to add to this.
No, I was just going to say that certainly we welcome new members, and what we strive for in any steering committee and any work group is national representation from all our participants. So we started out recruiting those who we know have been involved and participating, so leadership from those organizations. But certainly if you are contemplating joining in, you can rest assured that we will welcome representation at steering and on the work groups.
And it's Sonia. I just would like to add one piece. We're really trying to be respectful of not tapping into the same individuals in the steering committee and the working groups. We're really trying to harness the wisdom and the experience of key individuals to partake in separate groups or steering committee, so that we're able to move this along in a very purposeful way and ensuring that we're harnessing those spheres of influence that individuals have.
Absolutely.
And yes, Sandy, the working groups haven't been established yet, and we're going to be looking at populating those. There'll be an implementation working group and I don't remember what else. I think a technical data element working group. But so we'll be looking at first the initial membership of our steering committee. Some of those individuals may actually move on to one of the working groups. And then, as Sonia said, we'll be looking at making sure we have kind of cross-sectional representation on that steering committee, and welcome enthusiastic participants to join us.
I'm not sure if we mentioned, but if not, my apologies. But both Sandy and Sonia are the co-chairs for the PRRS Steering Committee.
So their leadership will continue and is integral to where we're going. Dr. Failings, I just wanted to mention that participation and that expectation for leadership, either on steering committees or working groups, is really the fabric of how we work. So I think that if there's an interest and a will, those expertise are needed and warmly welcomed. It's really how we do our business, and it has to continue that way. So I really appreciate your question.
All right, so are there any other questions? Anyone would like to make a comment, either type it in or to speak a comment, please click the raise your hand button. We don't have anything, we don't have anyone jumping up right now, but is there any other comments from our panels?
So Doug, will this presentation be available on the CAPHC website for people who couldn't attend but are interested?
I did record it just for that reason, so we do think it would be a good one. I wanted to make sure we, actually got the information out accurately before I promised that. But yeah, I think this went well, so I think we can certainly post this somewhere.
Now that we know it went well, we're willing to post it. Yeah.
But I think certainly the slide deck, I think, could be up on the website as well.
And we can certainly do both, yeah.
Mm-hmm. Absolutely. And I think that's maybe something we haven't mentioned sort of as a smaller bullet under our commitment to knowledge translation and communication, and that is that we will continue to use not only email, webinars, go-to meetings. There will be some face-to-face meetings in conjunction with CAPHC's annual conference this year in Calgary. But we will also use our knowledge exchange network going forward, which is a wonderful resource and opportunity for us to communicate important information, tools, etc., as well as, of course, the CAPHC website. And I'm not sure, Doug, if this presentation will go up on Ken on the Knowledge Exchange Network or...
Yeah, we'll have to see where the best spot is.
Yeah, but we'll let folks know how to access the information for sure.
And if questions come up at a later point, or for some reason you don't feel comfortable asking here, please feel free to contact any one of us, and we'll direct the question to the appropriate person and do our best to get you an answer.
I took the words out of my mouth there.
Exactly. Yeah.
I'm really glad you said that, Sandy. And so, if there are no other questions at this time, Sandy, your words are very kind, and thank you. I want to turn those words around to our co-presenters around the CAPHC table today, as well as around the country. Thank you. Sandy, Shauna, Sonia, Heather, for your leadership, your continued leadership. I really want to recognize Doug Maynard's stewardship and leadership of our rehab program going back to 2000. Well, I can't say 2004. Doug joined us in 2008. But I do want to recognize, Doug, your leadership and say thank you. The road ahead is a very exciting one. Come and join us. Come and be a part of this exciting opportunity. We're very committed to keeping everyone well informed and a part of the development going forward. And I guess the very next step, we'll be in touch with everyone who's participated on today's webinar, sort of toward mid to late May, with that invitation package. And in the meantime, as Sandy said, please don't hesitate. If something comes to mind an hour from now, pop us an email, and if we don't have the answer at our fingertips, we will get that information for you and get back to you. And probably the best person is our Rehab Reporting System Project Manager, and that is CM Javid. also just emailing CM directly, and I'm not sure if we can put up CM's email address right up on the screen, which is probably a good way to do it. Okay. So again, don't hesitate, and we'll sort of coordinate all feedback sort of in one email box, which is probably more efficient. And if there's no other questions or comments, again, thank you to all for your participation and leadership today, and we'll be back in touch very soon. Thanks, everyone.